name is Comfort Musa. I am a journalist and social worker, joining you from Yaoundé, the capital city of Cameroon. And this afternoon, we are very excited to have participants from every region of the continent. I see people from Mauritius, from Nigeria, Malawi, Kenya, South Africa, all over. You are all welcome. And as we carry on, please, I would kindly ask that if you are not speaking, if you're not one of the speakers, please mute your microphones, and if you have to speak, we'll let you put it on so that we don't have obstructions from the background. And also, as the webinar proceeds, if you have a question or a comment, leave it in the Zoom group chat and we will look at that. Just a few housekeeping rules for us all. Again, you are all welcome to today's webinar. Before we get on to meeting and hearing from our wonderful guest speakers today, I would let Action Amos, our convener and vice president for IBE Africa, formally welcome us.
Thank you, Comfort, and welcome everyone on behalf of International Bureau of Epilepsy Africa, as well as International Bureau of Epilepsy. I would want to welcome everyone to this webinar. Also to welcome the President of International Bureau of Epilepsy, Professor Martin Broad, who is among us, and also to welcome our main funder, who has also joined us, Gardner Lapham from Bend Foundation, who have supported us throughout the past years, and all directors from our different you're most welcome. Sorry, friends, if we can ask you to mute, and welcome everyone across Africa. We have people from Mauritius, Eswatini, we have people from Namibia, Gambia, UK, Sudan, those that I can see, yes, Malawi, Zimbabwe, quite a number have joined Cameroon. So everyone, welcome our friends, and we're looking forward to a good discussion with our invited guests, Dr. Symon Kariuki, as well as Professor PLO Lumumba, who is a friend of ours, and I'm glad to say he was here in Malawi. Yeah, we had a good time during his presence. So thank you so much. Back to you, Comfort.
Thank you for that warm welcome, Action Amos. And this is our 5th webinar. We just want to say this session will be recorded, and of course it will be available online for those who would want to go after, you know, and listen again. One thing that has happened with every webinar we've had in this series is the momentum that is building, the strategies that we share, and after each webinar, we feel like we are making progress. And today we are going to make yet more progress. If you receive the invitation, I'm sure you are excited, as I am, with the quality of resource persons that we have. They have the experience, they have the wealth of knowledge and experience that we need for this topic today. And straight away, I will introduce our first speaker. When he comes on, please, if you have a question for him as he speaks, leave it in the chat. And when it's time, we're going to take your questions. So we have with us Dr. Symon Kariuki from Kenya. He is a scientist at the Kemri Wellcome Trust Research Program in Kenya, where he co-directs neurosciences research, and he is a chairman for the Kenya National Epilepsy Coordination Committee and a member of the advisory committees and task forces for various epilepsy and health-related organizations, including IBE Africa. He initially qualified from University of Nairobi and consequently from King's College London and University of Oxford. Good afternoon, Dr. Symon.
Good afternoon, Comfort, and thank you very much for the opportunity.
Oh, Dr. Symon, I tell you something before you continue with your presentation. I shared this poster widely to invite friends and colleagues and activists in Cameroon. and someone saw it and said, oh, Dr. Symon is going to be on it. I know him, he's an amazing researcher, so I will join. And we are happy to have you. Your work is well known, and we're glad that you're going to share that knowledge with us this afternoon.
Yeah, thank you very much, Comfort, for the kind words, Amos as well for the invitation, and to the International Bureau for Epilepsy, our Africa region, for this opportunity to speak in this important meeting. And I will be speaking on the gaps and the challenges for epilepsy in Africa. And to start with, is just to let you know that I'm based at the Kemri Wellcome Research Program. And as Comfort has said, I'm a researcher by profession. And the Kemri Wellcome Research Program is a collaborative program which was founded in 1989 and initially focusing on studies of severe malaria, but subsequently evolving to focus on causes of important morbidity and mortality in the region. That is in Kenya, Uganda, East Africa, as well as in other parts of Africa. And it's quite a large research program with about 100 active researchers, as well as a number of supportive staff supporting the work going on in the region. And in addition to that, I'm also involved so much in advocacy and awareness initiatives for epilepsy, which I've been able to achieve through serving as the chairman for the National Epilepsy Coordination Committee, a position which I took up in the year 2016. And I've been working closely with the colleagues that you can see there, as well as various other epilepsy stakeholders, including the government of Kenya, the Ministry of Health, as well as other non-governmental and community-based organizations. And working together with this fantastic team, we've actually grown very exponentially in the last 6 years also. And it's because of their long-standing commitment and dedication to service. So I'll be speaking today about the gaps in epilepsy care in Africa, and I'll be focusing mostly on bridging gaps in bridging the diagnostic, treatment, and knowledge, and also on primary prevention of epilepsy, because as many of you already know, symptomatic epilepsy is very common in Africa, which suggests that primary prevention may help. And also I'll be touching on the human rights promotion for people with epilepsy, focusing specifically on empowerment of individuals, advocacy for self-representation, as well as providing the necessary support and care, then the role of research and monitoring, as well as the partnerships that we need to have with the government, as well as other stakeholders, so that we can be able to reduce these gaps together. So I just start first of all by asking the question whether indeed epilepsy is a serious problem in Africa. And you'll all agree with me that it is a very serious problem. And we can see that the burden from the previous studies that have been conducted by researchers from the Kemri Wellcome Trust program shows that the prevalence is about 10 per 1,000. And those who come from high income countries know that the prevalence there is around 4.5 to 5 per 1,000, which means that the burden that we see here in Africa is 2 times that seen in high income countries. And also it's good to mention that that is based only on the burden of active convulsive epilepsy. So if we add non-convulsive epilepsy, the prevalence almost doubles to 20 per 1,000. And then we also have a very serious challenge of acute encephalopathy and other associated problems of acute infections, including acute seizures, which we've been able to find that over time, they can be able to increase the risk for epilepsy. But we are definitely here to emphasize that an acute seizure is not epilepsy, and we will be seeing that when we are looking at the gaps. So we've also been able to conduct studies on the preventable risk factors for epilepsy in Africa. And the reason why I'm presenting this slide is just to be able to indicate to you that most of the risk factors are very easily preventable. For example, the adverse perinatal events or perinatal complications, if you like, traumatic brain injury or the head injury, as well as other parasitic infections, including falciparum malaria, as well as others which are common in this area, so much often related to transmission by the pets. And we also want to let you know that epilepsy does not only occur as a single problem, so there is actually more to worry beyond the seizures, because we've been able to find that it is often co-occurs not only with mental health problems, but also with other medical comorbidities. And when you have that multimorbidity, it tends to significantly worsen the well-being, as well as lower the quality of life. And we've been able to demonstrate that in our studies here in Kilifi. As you can see there, mental health problems is significantly greater in those with epilepsy in blue there than in those without epilepsy in red. And conversely, when you look at the quality of life, it is significantly lower in those with epilepsy than in those without epilepsy, which simply means that there is a need for development of comprehensive care packages for people with epilepsy in collaboration with epilepsy specialists, as well as other partners in government, as well as epilepsy organizations. So I'd like now to delve on the shortages of healthcare providers in general in Africa. And you can see there in the y-axis, I'm showing the extent of burden of disease in Africa. And it appears like Africa is accounting for about 25% of the global burden of disease. But if you relate that to the healthcare workforce that is working to manage these problems, you find that Africa, perhaps followed by the Eastern Mediterranean region, has the lowest number or percentage of the global workforce at 5%. And it's usually very sad when you look at other WHO regions like Europe and Americas, which are contributing a very small burden of disease, but they have a very high percentage global workforce compared to Africa. How does this compare with the mental and neurological disorders? This is a slide that I obtained from the World Health Organization. And you can see there, worldwide, we only have about 1% of the human resources committed to reducing the treatment and diagnostic gap for mental and neurological disorders. Majority of them are actually not trained to handle these problems because they are either nurses or they have any other qualifications. And I think the most challenging issue is the ratio, because you only have about one psychiatrist for about 100,000 people. And that is actually way below the recommendations that are given by the World Health Organization. So at the moment, we can conclude that Africa will need to increase its current workforce by 150%, which, as you may already start thinking, is very expensive to achieve, and we'll be able to see what other strategies we can use to go about that. So I've mentioned about the concept of the psychiatrists to population ratio. For neurologists to population ratio, who are very important in the management of epilepsy in Africa. So there is very limited data as far as this is concerned, but using the estimates that are available, it is even far much worse than psychiatrists, because it is less than 1 per 1 million population. And if you compare to other settings, you can find up to 10 neurologists per 100,000, and that is not 1 million, meaning that we really lag far behind with that. And if that is not enough, you'll actually find that there is no significant effort and investment in training programs in many low and middle income countries, including Africa. And this definitely calls for the need to come up with novel approaches, obviously using the limited resources that we have in Africa to try to reach out to each and every person with epilepsy so that they can receive appropriate care. I'll talk about the diagnostic and treatment gap, and the most reassuring thing is the fact that epilepsy diagnosis can be made easily through clinical history, and the epileptologists who are here, the clinicians who are here know that you just need a history of 2 unprovoked seizures. But despite it being that simple, there are also challenges in being able to make the diagnosis. For example, we rely on people bringing themselves to the facilities, and the downside is they can only be able to identify some forms of epilepsy, especially those with the generalized tonic-clonic seizures, and those are the ones with the focal seizure. They will not be able to identify them, and they may end up not bringing themselves for hospital. And then another challenge is the fact that people with the conditions that are not epilepsy will end up being misdiagnosed, or those with epilepsy will not be diagnosed at all. And that is a very serious challenge. And a perfect example of what may be missed from diagnosis is non-convulsive seizures. And like I indicated initially when I was starting this discussion, in Africa, most of the studies have been able to detect active convulsive seizures. There is a very significant gap in detection of non-convulsive seizures. And then there is also this other challenge of epilepsy stigma, which is deterring so many people in the population and in the community from visiting biomedical facilities to seek care. And then also the logistics that are needed, for example, telemetry, which is video EEG, which might be a very useful resource in differentiating non-epileptic psychogenic seizures from epileptic seizures. Most of these resources are not very much available in Africa. Even if they were there, additional training would be needed so that they can be used. And then the challenge of febrile infections, which increases the incidence of febrile seizures, especially in children under the age of 6 years. It is an important area that needs to be invested in so that we don't have febrile seizures being confused as epilepsy, or the other way around, parents imagining that all seizures in early childhood are febrile seizures, even when they are epilepsy, and these children end up not going to hospital. So with all those factors, then what happens is there is missed opportunity for treatment. And when the treatment gap is large, then you have the risk for premature mortality, people dying earlier than their life expectancy, age, and obviously other indirect and warranted costs, as well as adverse events from anti-seizure medications for the people who would not have been diagnosed for epilepsy in the first place. So I continue with the diagnostic gap, and as you can see there, you may need electroencephalography and also magnetic resonance imaging to be able to classify epilepsy in Africa. But looking at the availability of these facilities, you can see that they are not readily available. For example, for EEG, it's only Algeria, South Africa, and probably Kenya, which has a reasonable number of EEGs. And South Africa is quite very fortunate because even when you go to the availability of CT scan and magnetic resonance imaging, they are doing far much better than any other countries. So the treatment options for epilepsy, more often than not, we talk about anti-seizure medications, but there are also other options which are available in high-income countries. For example, surgical treatment, vagus nerve stimulation, deep brain stimulation, as well as ketogenic diet. But unfortunately, many of these treatment options are not routinely available in Africa. And even for anti-seizure medications, at the moment, we have the standard anti-epileptic drugs, and the newer anti-seizure medications are only available in private facilities, or they would need a patient to spend money so that they can be able to purchase them from the pharmacies. So we think that because of the high incidence of symptomatic epilepsy, epilepsy surgery may be a very potential option for managing epilepsy in Africa. But there is a paper here published in Epilepsy Behavior, which shows that it's only 7 African countries, South Africa, Morocco, Algeria, Tunisia, Egypt, Kenya, and Uganda, who have been able to perform epilepsy surgery on people with epilepsy. And in some of those countries, they have been able to do so either without invasive recording or with the support from experts from foreign countries. So I think this is an area really that needs to be invested in so that those patients with epilepsy with amenable regions can actually have them removed and probably get a complete cure for their problem. So we also have challenges on anti-seizure medications. I've mentioned that we only have the standard anti-epileptic drugs, and we know that the treatment gap is very large based on the studies that we've done, with about 64% of the people with the epilepsy not receiving appropriate treatment because of obvious reasons to do with the costs involved in purchasing those drugs, animistic drugs, as well as misperceptions about epilepsy, erratic supply of anti-seizure medications, having to walk very long distances to go to biomedical facilities, as well as the limited number of specialists to manage these problems in Africa. So we also did some work together with other countries in Gabon and in Madagascar, collaborating with the scientists from France. And we did find that sometimes the quality of anti-seizure medications in Africa is also not very good. Although the good news was that the quality was poor because of poor storage environments, but we didn't find any evidence of any counterfeit materials or lack of active ingredients in the anti-seizure medications. And most important gap is the lack of political goodwill and commitment from the government. And I think one of the first challenges is usually a strategy on how to increase awareness of epilepsy in policymakers and decision makers in government. And also this obviously is because of the lack of a commitment to resources for epilepsy care by the government as well as other international health organizations. We've seen unprecedented investments in other infectious diseases, but we don't see equal commitment when it comes to non-communicable conditions like epilepsy. And there is also the concept of epilepsy not being included in the national health plan, because once you have the national health plan, then you can have it registered in the public health policy, which will be under the custody of the Ministry of Health of each country. And with that, they can be able to allocate resources for epilepsy care. Then something that is almost common to many African countries is the low economic development, which obviously goes hand in hand with the knowledge about epilepsy, as well as adoption of any solutions and interventions that might be suggested to the populations. Last time, challenges on misperceptions about epilepsy, which I would say is as old as mankind, and it is documented by medieval physicians, whereby Babylonians and Jewish believed that when you had epilepsy, you are either possessed by an evil spirit, and therefore they resorted in using exorcism, or if they don't succeed, then you are socially marginalized, which we see nowadays as discrimination. And the book that is indicated there was written by a Catholic clergy, and it's called Malleus Maleficarum, a 15th century AD book. And the sad thing is it actually adopts the extermination of witches, using actually detailed legal and theological basis, because they do believe that it is witches who are causing epilepsy during that period. And therefore, you can see that the problem that we are grappling with today is as old as mankind. So I'm going to briefly highlight some of the solutions that we can use to some of the gaps and challenges that I've highlighted. And the first one is on the primary prevention of epilepsy. And I think that if we can be able to appropriately use the primary health care core activities as outlined in the Alma Ata Conference of 1978, we can really address so many of these problems. For example, creation of awareness and sensitization on the causes and consequences of epilepsy, not only targeting the community and the people with epilepsy, but also those in high offices, a promotion of proper nutrition, especially micronutrients, as we already now know that they do contribute to brain function and development, which is associated with the epilepsy, safe water provision, which can reduce the transmission of parasitic infection that cause epilepsy. And most important from the figure that we give is improvement in maternal and child health, which is thought to prevent about that can prevent about that percent of epilepsy in Africa. And obviously, adoption of immunization programs, and especially those against infections that can affect the brain, as this can be able to prevent epilepsy. And obviously, that goes hand in hand with the control of endemic infections. Then there is also need to invest significantly in terrain neurology, which I think is still growing. And as you can see there, there is a strategy that was suggested by Safo et al., whereby those countries in West Africa, because they are very close to Europe and North America, can actually be able to form regional networks together. And then from there, then the knowledge that is gained can be able to be shared with other regions in Africa. And the benefits for this is the fact that it is going to be very convenient because it will decrease travel time and expenses. And it's also going to be very good for capacity building as people learn virtually, that is clinicians and other healthcare providers. And it's also going to bring about group education for patients with epilepsy. Then we have an important program from the World Health Organization called the Mental Health Gap Action Program, simply targeting training of primary health care providers so that they can be able to identify and manage epilepsy as well as other priority mental and neurological disorders. And the concept here is premised on the distribution of health personnel in Africa. As you can see, personnel with the prescriber capacity there, doctors, it's 15.4 per 100,000. But if you invest on clinical officers, nurses, and that's the enrolled nurses as well as the registered nurses, you may be able to increase a prescriber capacity to 157 per 100,000, which I think is even going to be a number greater than even what we see in high income countries. If you can be able to train these people and then you combine this with the novel approaches such as mobilization of non-governmental organizations to raise awareness about epilepsy and to support people with epilepsy, as well as invest a lot in strengthening of the healthcare system, I think this approach can have a very significant impact in reducing diagnostic and treatment gaps for epilepsy. And obviously there is need to form national coordination committees in each country so that there can be coordinated epilepsy services in each country. And then members obviously can also be sensitized about availability of resources and the people to network with so that they can collaborate with them and reduce the treatment gap of epilepsy as well as create awareness about the quotation. Another important thing is a situation analysis for epilepsy. Like I said, without empirical data, and I'll be repeating that again in the subsequent slides, you cannot be able to design a national policies, strategies, and plans. And the countries are really encouraged them to do this, and it should be a comprehensive situation analysis which encompasses the full range of current and potential future health issues, as well as any other determinants for epilepsy development as well as care. And action plans for situation analysis, you just need some simple information. Some of them are even readily available in the community and even in the hospitals. For example, the burden of diseases and also health system performance and capacity gaps needs to be identified. So I've provided the steps there. You can go and read more about them. You just need to gather information, appraise the quality of data, and then finally write a report. And you can do that together with other partners, the Ministry of Health, International League Against Epilepsy, International Bureau for Epilepsy, and then obviously consulting the World Health Organization. And when you have the report ready,
Hello,
Hello, Dr.
Comfort?
Symon. Yes, it looks like we
Sure.
lost
I think
Symon.
Dr. Symon has hanged, and yeah, I think he has left actually. So maybe because Professor Lumumba is going to be affected by a curfew in his area, maybe he can take it over. Hello, Comfort? Hello, Comfort?
The bit that we heard, he not only spoke about the gaps, but he went detailedly into solutions that can address these gaps. Straight away, we will look at why are governments in Africa turning a blind eye on epilepsy? If these gaps are known, researchers have said, these are the gaps, this is what can be done to fill the gaps. Why is it not being done? Why are the governments in Africa turning a blind eye on epilepsy? For this, we have a guest speaker who probably doesn't need any introduction on the continent, Professor PLO Lumumba. He's a consultant with Lumumba and Lumumba Advocate, a member of the Africa Justice Group. He's an advocate of the High Kenya and Tanganyika and a certified mediator. He has authored several books and is recognized as one of the leading public speakers of the continent and the Africa diaspora. He's founder of several organizations, including PLO Lumumba Foundation, a charitable organization in operation since 1990. He has been twice recognized as one of the 100 most influential Africans, and we are very happy to have him with us this afternoon to help us understand why governments in Africa are turning a blind eye on epilepsy. Good afternoon, Professor.
Yeah, good afternoon. Let me start by congratulating the International Bureau of Epilepsy and the African Bureau of Epilepsy for organizing a webinar around a medical condition which is not very well understood. I note that my very good friend, Dr. Symon Kariuki, had already started intervening in a very technical area, which indeed is his area. But the question that you want me to deal with is non-technical, but yet very important. Indeed, it is coincidental that exactly 20 years today, on the 27th day of April, the year 2001, African leaders met in Abuja in the Federal Republic of Nigeria and declared that the countries would spend 15% of their annual budgets on health. The story, as you and me know, is that no country has succeeded in doing that. Of course, there are few countries that have moved in that direction, like Rwanda, Botswana, Namibia, but even those countries that have done well have not achieved that. The significance of that is that African budgets have not been deployed in a manner that is capable of dealing with all health issues. And if there was any doubt about it, the manner in which we have responded to the COVID pandemic is generally indicative of how weak our health systems are. When we talk about ICU facilities, when we talk about the availability of vaccines, we talk about the availability of nurses, of doctors, and even if they are there, the facilities that are available to them is not anything to write home about. So while we may say that the governments have turned a blind eye to epilepsy, the real issue is that many governments have turned blind eye to the entire health situation. And in many cases, when we respond to health issues, it is almost on a crisis basis. But Africa finds ourselves in a very unique position as regards epilepsy, which, as Dr. Kariuki alluded to, is a disease that is very thoroughly misunderstood in many nations and communities in Africa. Many of you who are listening and participating in this webinar will know that epilepsy is attributed to witchcraft. Epilepsy is attributed to curses. It is attributed to many other things which cannot be explained scientifically. And I dare say that even the individuals who have the honor and privilege of serving in African government don't understand epilepsy and therefore don't give it the pride of place when we are talking about the diseases that afflict Africa. But yet, it is one of the most debilitating conditions. It is one of the conditions that affect people, and it affects them in secrecy, because people who are afflicted by this condition are oftentimes stigmatized, and the stigmatization leads to ostracism, and that in itself does in fact affect the manner in which the medical world also treats epilepsy. But that is not to say that African governments have not paid attention to the problem of epilepsy. Those of you who are familiar with the issue of epilepsy will remember the African Declaration on Epilepsy in the month of June and the month of May in the year 2000 in Dakar in Senegal. African governments sat in Dakar in Senegal in the year 2000. In fact, that was a year before the Abuja Declaration on Health. And the Dakar meeting did identify the fact that epilepsy was a disease that ought to receive the necessary attention because of its impact. Indeed, the statistics which will be shared by experts will demonstrate that aside from Latin America, I think that Africa is the one that labors under epilepsy more than any other continent. But I leave the scientifics and the statistics to those who are better educated in that area than I. Mine is to raise and flag out the issues which are of a general nature, and that is where the Dakar Declaration comes in. And to demonstrate that African governments who are actually concerned about it, at least as animated by the scientists in the area, a year later in Harare, there was a consultative meeting, which was a follow-up to the Dakar Declaration, which was designed to understand how the Dakar Declaration had been implemented. But as you appreciate, many African countries have had different economic problems, wars and other things, and therefore the budgetary allocation to a condition which is not given the prominence of Ebola, the prominence of malaria, the prominence of water diseases, is that it is neglected in many ways. And you will be told by the experts who are present in this assembly that even in the medical world, even those who are trained as scientists, in their unguarded moments, they relapse into the belief that epilepsy is witchcraft or a curse. So we come from heavy burdens in our society, and it is necessary that our African governments ought to be educated. And an interaction such as the one that you are having today ought to be one of the avenues via which African governments are educated. And I'm glad that the president of the International Bureau is here. I'm glad that those who are present at the leadership level in Africa are here. I'm glad that the researchers are here, and it should not end here. Because one of the problems that we have in Africa is that we have these jamborees, either virtual or physical, and we produce a lot of good ideas. And these ideas are then shelved so that policymakers and decision makers are not involved. I would have loved, for example, that in a webinar such as this, all African ministers for health come in and participate from the beginning to the end. Because one of the problems with African politicians that they come at the opening session, once they have read speeches that are written to them, then they disappear. And they have no idea completely what has been discussed at those sessions. It is important, therefore, that as we go forward, we recognize that indeed African governments have recognized that epilepsy is something that ought to be dealt with very seriously. And perhaps now that we have the Center for Disease Control, the 5 of them, with the headquarters in Addis Ababa, Ethiopia, I think one is in Gabon, one is in Zambia, one is in Kenya, and one is in Egypt. The 5 Centers for Disease Control and Research Organization, the Malagasy Institute of Applied Science, the Louis Pasteur Center in Dhaka, Kemri, and the different organizations should now focus on epilepsy as one of the major diseases that require attention. I know now that COVID has captured the attention and imagination of all of us, but we ought to remind ourselves, as I've seen people being reminded that COVID is here with us, but epilepsy is also here with us. HIV/AIDS is here with us. Malaria is here with us. Ebola is here with us. And lest we forget these conditions which are present with us as we pursue COVID, it is important that we remind ourselves, and I cannot emphasize enough that this webinar has come at an opportune time when African countries and African governments are now ruining the days when they did not set aside sufficient funds for the health sectors. And I believe that if we trace our steps a little backwards and we go to Abuja in the year 2001, we will recognize that we ought to have set aside 15% of our national budgets for purposes of ensuring that we have health and health sector as a place that deserves attention. Once again, I believe that if we go back to the African Declaration on the question of epilepsy as was articulated in Dhaka and the consultative meeting in Harare in Zimbabwe, we will be able to recognize that indeed there is need for something. At forums such as this, beyond criticism and beyond critiquing our governments, we also ought to appreciate that governments are now suffering in a real way. There is not a single African economy that I know now which has not shrunk in real times. And I think that it is not only governments that we should talk about. We should talk about private sector. In other parts of the world, the private sector is very active in supporting government in a deliberate and creative way, particularly in the area of research. If we could, and this is where once again governments come in, if government could create tax incentives so that the private sector could collaborate with research institutes and deploy money for purposes of ensuring that research is undertaken. When my good friend, Dr. Kariuki was speaking, and I saw the distribution of the resources, you can see that the availability of resources and equipment is very much a product of economic ability. It is Morocco, it is Egypt, it is South Africa, which means that you have outside or in sub-Saharan Africa, the only 2 countries that we are talking about at different levels is South Africa, to a very less degree, Kenya and Uganda. If you go to the entire Sahelian area, the entire Sahel, not even a single country. And when you go to the Maghreb, it is only Morocco and Egypt. That tells you that until and unless the private sector also weighs in, we are going to have these declarations, we are going to have Abuja, we are going to have Dhaka, we are going to have Harare, we are going to have Eswatini if they come and others. But the truth is that our words will not be matched with the necessary funds. And as I conclude, Africa has no shortage of men and women who are properly trained. There are men and women who are properly trained both in the continent and outside. If you look at the researchers and doctors who are resident in Europe and America who are of African origin, they are there. The only reason why they cannot come to Africa is that when you come to Africa, you find yourself handicapped because you have no resources, you have no equipment, and the environment itself is not incentivized. So I hold the view, as you continue with this webinar, that you will benefit from the contribution of experts, and that those experts will and the organizers of this particular webinar will compile the proceedings of this engagement in a manner that is useful, so that we go out there and engage government in a positive way. I believe that if we do that, then all of us, our hands will be on board, and we will be able to help ourselves and help our government. And let me say, whenever we talk about governments, we must never see governments as being apart from us. We are part of the government. We only, when we talk about government, we are talking about the administrations at that time. And being members of the government, we also have a duty to play to ensure that we create awareness in our own spaces. And if we do that, then I have no doubt that our governments will wake up and that some useful resources will be dedicated to epilepsy, which, as I've already said, is a disease which suffers from stigmatization and which is not well understood even by those of us who have had the advantage of formal schooling. God bless you.
Thank you very much, Professor Lumumba. Again, this session is being recorded, and so we can come back to it and listen over and over. We have a few questions for you before you take your leave. Action, Amos. Please, for those with questions, we encourage you to keep it simple and short, straight to the point. Action, Amos.
I think there was one question that came through a text message to Prof. It's about how he sees interworking with other partners within the region, especially African Union, Pan-African Parliament, and other institutions of goodwill. So maybe a comment about our institutions within Africa.
You know, Amos, one of the things that I've discovered as I look at Africa, there is no shortage of institutions. Number one, there is no shortage of declarations. There is no shortage of good research work. There is no shortage of men and women who have been properly trained or who are waiting to be trained. There is sometimes in a number of countries, even the laws are there. Even the policies are sometimes there. I think our weakness is implementation. And implementation comes about because we don't have the financial resources. And my view, therefore, is that collaboration is very important. And if you look at the research institutes that are now around and about Africa, if only they collaborated so that what is happening in Dakar is known in Madagascar, is known in Eswatini, is known in South Africa, and is known in Tunisia and in Niger and in Mali, then you would be amazed. The universities in Africa don't even have meaningful exchange programs. If you ask many of the doctors who are present here, they have had exchange programs with Oxford, with Johns Hopkins. But if you ask a doctor at the Anti-Seizure hospital in Senegal whether they know of a program in Nairobi, Kenya, or Dar es Salaam or Makerere, they don't know. And we now know that the research funds that are given to us from Europe and America, only a small percentage of it actually remains in the continent. And my own view, easier said than done, some may say, but if we focus on research and development and under the aegis of the Centers for Disease Control, luckily now we have things working in our favor. One, you have a very strong person who is at the WTO in Okonjo-Iweala. How can he work with that? You have Bianyima at UNAIDS. You have, see, the Tewodros, who is at the World Health Organization. You have the Centers for Disease Control, the 5 of them. If all those efforts are coordinated, Amos, I can tell you within 2 years, you will begin to see movement of an amazing nature. So one of the things, as I conclude in answering that question, is I wish that Africa should now halt and said, we have made enough declarations. We have made enough laws. Can we take the following 5 years to implement what we have declared, what we have undertaken, and deploy funds in that direction? And my good friends who are here will tell you that there are Africans outside in the diaspora who would want to share the expertise that they have acquired over the years with people in the mother continent, but the circumstances must be created which will enable them to do that. If we can't all have labs, let us SADC have a good lab, one good lab in South Africa. Let East African community have one good lab in Dar es Salaam, let Morocco, and let me tell, and the Horn, we have one good lab in Addis Ababa, and you'll be amazed at our ability. It is not because of inability, it is lack of coordination and lack of deployment of resources.
Professor Lumumba, we understand that you're rushing to beat the curfew, so we'll take just one more question for you. In the first presentations with Dr. Symon, he gave us statistics about situations of a country where you may have 1 psychiatrist to 100 patients, and this gross lack of specialized skill. And I hear you clearly when you say that we have this specialized skill, but it's out of the continent. What, in your opinion, would be a good way to mobilize African specialists in the diaspora to serve on the continent? How can we?
At the end of the day, I think experts, and there are experts in the medical field present in this webinar, an expert will tell you, in order to fulfill myself at the highest level of expertise and professionalism, I need facilities. So provide them with facilities. Number 2, I need resources. If I want reagents, if I want equipment, I want the equipment to be available so that I can deploy my intellectual resources effectively. And once I have the resources and I have the working environment, I want to be in a position and to be enabled to consult with expertise and experts outside or within the continent. I think we don't do that often enough and well enough. And slightly off epilepsy, see the number of nurses that we train in Africa, and half of them then run away to the United Kingdom. We give them the finished product. Look at the number of Nigerian doctors who are practicing outside of Nigeria, or Ghanaian, or Cameroonian. I know Dr. Folefak, who is my friend, who is one of the leading doctors at the University of Ohio in Columbus. He could be, if there were circumstances which were favorable in Yaoundé or in Douala, he would be there. But he prefers, because of a number of reasons, to remain there. And I'm sure you can count a number of Cameroonian doctors who are scattered in France and other places, and our friends in Eswatini. So I think what we should do is to create an environment that attracts our professionals. Some of them are prepared to sacrifice. I've met doctors. I met a lady, doctor in Austria, who is from Zimbabwe. When I said people should come back, she told me, I can hear you. But when I left Zimbabwe, my salary was the equivalent of $5. Should I have remained? I said, no, you should have gone. Because she told me I have children's school fees to pay. But she told me, if they can pay me $1,000 instead of the $5,000 that I'm earning here, I would go back home. But there is no shortage of such people outside of the continent. And that is where I think you are in this space beyond what you are doing as technicians. Do know that is not for the faint-hearted. You'll knock 10 doors before one opens. And once you know that, you will do it again and again. And I think that even within African bureaucracies, there are people who are now beginning to realize, perhaps that is one of the things that COVID has brought about, that for the first time, Africans, particularly the political class, cannot go to Europe and America to seek medical attention. They are now being told that when you are sick, you've got to be in Africa. And for that reason, I suspect that in the next 5 years, you are going to see a lot of investment in the health sector. And that is a good thing. If there was a silver lining or in this cloud that is called COVID pandemic, that is it, the increased financing in the health sector. Thank you very much.
Thank you very much. Thanks for your time, and thanks for sharing this time and the knowledge with us. We understand you have to take your leave. That is great. We will continue with the other questions for Action, Amos, and Dr. Symon. Thanks again, Professor Lumumba.
Thank you. Thank you very much.
You're welcome. So Amos, there is a question that came in for you, I think. So when I read the question, I knew like this would be, the response would have to come from someone in the IBE. So the question is from, sorry, I just need to scroll to see. So the question is, what is the best approach for IBE to liaise with the 5 centers for disease control in Africa? Since we were talking about collaborations and partnerships, this came in on what would be the best approach for IBE to liaise with the 5 centers for disease control on the continent.
Well, I think that's a very good question. Well, we need to understand well the strategies and the policies
and that just to say, that question was from Mary Sepo.
Oh, okay. I think it was also been directed to Professor Lumumba, and he partly touched on it when he talked about looking for collaboration with these centers in terms of research. We know they are well funded, they have good resources, but it is for us as organizations that of persons with epilepsy to understand, where they're coming from, the areas that they are working in. By understanding the environment and the policies and strategies that they've put, we'll then have to see in which areas can they mainstream issues to do with epilepsy. So that gives us a lot of homework on, that potential partner that we can work with. Thank you.
Okay, thank you. And just to make sure we have Dr. Symon before I take the questions that came in for him. Dr. Symon, are you back?
Yes, I'm back, and sorry for the impromptu disconnection because of internet challenges.
Yeah. So we're glad to have you back, and you covered, I'm sure you covered all that you had prepared for us.
Absolutely.
Okay, great. So there is a question that came up for you I have it by text. Is there any initiative on the continent or in some African countries to train and retain professionals in this domain? Are there any initiatives that you are aware of? The acute shortage of professionals that cater to the need of patients with epilepsy, you highlighted that. And the question is if there is any initiative or program to train and retain these professionals on the continental level or in some African countries. Are you aware of any?
Yeah, so I think I would approach that question in 2 ways. So first of all, I'm very much aware that in South Africa, there is a pediatric training program on neurology that is done at the University of Cape Town, where you have doctors go there, spend about 1 or 2 years, and then they are trained on how to manage neurological disorders, including epilepsy. And then I think as far as the other countries are concerned, the best partners working on that is the World Health Organization. And they have tried to implement the World Health Assembly Resolution 68.20 to sort of like pilot the utility of the mental health gap action program in training healthcare providers in the management of epilepsy. And I'm aware that the pilot studies have happened in some countries, specifically Ghana, Mozambique, Vietnam, and Myanmar. And it's a pilot study, so we'll be hoping that from those findings, the work will be extended to other countries. Thank you.
Okay. Another question in the Zoom group chat. This one was addressed to Professor Lumumba. He's not there, but I'll ask you, Dr. Symon. So why is it, this is from Vusi Kumalo, why is it difficult to utilize indigenous knowledge systems with the same vigor that we pursue modern medicine in our attempt to find solutions purely relevant to the African DNA? So I take that again. Why is it difficult? And this question is from Vusi Kumalo. Why is it difficult to utilize indigenous knowledge systems with the same vigor that we pursue modern medicine in our attempt to find solutions purely relevant to the African DNA?
Yeah, so I think that Professor Lumumba had attempted to answer that question, and it would probably go down to what he said, lack of resources, and at the same time, a lack of training, and obviously lack of support from the government. And I think the reason why there is a lot of investment in alternative medicine, it's because there is no much regulation, so you can easily go to the field, pick the commodities and the herbs that you need, and then you work out treatment. But when it comes now to the modern medicine, it's very challenging, like he said, to continue working in an environment where you are not being supported, especially with the resources and especially with the training, and that's why many of the experts end up migrating. But I think going forward, there is a lot of investment in building capacity here in Africa, and we have so many other forums taking part in that. I'm aware about the African Academy of Sciences. It's actually playing a very bigger role in empowering African scientists as well as other healthcare providers, and also supporting some of them with the fellowships to come back to Africa so that they can come and work here, and encouraging collaboration within Africa, because our minds previously had been tuned to the North-South collaboration, but now there is a lot of emphasis on internal collaboration within the continent. And obviously sensitizations with the governments are needed so that you can now have the government committing more funding, not only towards research, but also towards healthcare.
Okay. Thank you very much, Dr. Symon. I think we have exhausted the questions. We have many comments, positive reviews of both presentations that we had there available in the chat. We may not be able to read all, but I encourage you to read them. There's good feedback for all of us. And we will be wrapping up at this point in time. We truly appreciate everyone who took time out to participate in this webinar. We appreciate the International Bureau for Epilepsy globally, especially that for the African region. Thank you very much, Action Amos. Please, there is a hashtag for these conversations, making epilepsy a health priority in Africa. I know that in the course of this webinar, there are things that stuck with you that you want to share with your communities. Please do use the hashtag so we can have more visibility and we can amplify this message greatly. And also, we will have another webinar. The next one will be on health laws and epilepsy in Africa. Look out for the announcement. And when you do get the announcement, we are kindly requesting that you share and that you invite other people. Also, look out for this recording. You can check the IBE Africa pages on Twitter on Facebook, and you can visit their website for past episodes of the webinar. And it's on that note that we are saying goodbye. Amos, any announcement from you?
Well, no, just to thank you also as our host. We really appreciate. Thank you.
Okay, it's always an honor to host this webinars. Let's keep the engagement. Let's keep the conversations going. Thanks again, and goodbye to all of you. Bye-bye.
Bye.